Hi, my name is Taylor Erickson, and I'm wanting to discuss the recent events and work being done on making a malaria vaccine. First, why a malaria vaccine? Malaria might not seem to be a prevalent issue for many people, and it can be set to the side. Malaria is a prevalent issue, especially in young children in sub-Saharan regions of Africa. Annually, more than 260,000 children die under the age of 5 due to malaria. This is 70% of the overall mortality rate for children under 5 in this area. There has not been much done over time, other than a medication that is impractical for many locals. The main type of malaria that causes these deaths is Plasmodium falciparum. There are 4 other types: P. vivax, P. malariae, P. ovale, and P. knowlesi. Our main focus will be on P. falciparum. Before we get into the vaccine, we need to know a tad more about the malaria and how it works. Malaria has a life cycle with 2 main hosts, the mosquito and the human. There are 3 main parts to this cycle: the exo-erythrocytic cycle, the erythrocytic cycle, and the sporangic cycle. So, to start, we have our infected mosquito, and it's getting a snack or a human blood meal. The sporozoites, getting into the bloodstream from this bite, will go and infect a liver cell. This is also known as the human liver stage. The sporozoites, after getting into the liver cell, will then mature into sclerons and rupture, releasing merozytes. After this, we enter the erythrocytic cycle. This can also be known as the human blood cycle. Our merozytes will hang around the erythrocytes or red blood cells and will invade and undergo asexual reproduction. They will become trophocytes after infecting and will repeatedly go through the process of maturing into sporozoites and then merozytes over and over in a repeating cycle. Or they can enter a different part of the cycle, and after turning into an immature trophocyte, they can enter the sexual erythrocytic stage and make gametes, gamocytes specifically. The male gamocyte is known as the microgamocytes, and the female are the macrogamocytes. Then we have our part of the sporangic cycle, when the mosquito takes a blood meal. These gamocytes will enter the stomach of the mosquito. They will sexually reproduce, making zygotes. These will then elongate, becoming eukaryotes. These eukaryotes will invade the midgut wall and become oocysts. These oocysts can rupture and will release sporozoites that enter the salivary gland of the mosquito and will then enter the human when bitten, restarting the cycle. So, what can we do to disrupt this cycle and stop so many young deaths? I spent a couple months living in Uganda. I was doing some humanitarian work. And in Uganda, malaria is a ever-present force. I had a pill that I had to take orally every day while I spent my time in Uganda to ensure I did not get malaria. This worked for my stay, but is not effective for many residents, since it is either not affordable or not very practical to take a pill every day. Most people I met treated this just like a nasty flu that they'd get every year or so, and there's nothing that they could do about it. So, here enters our vaccine as a more reliable, hopefully reliable, source for these people. Currently, there are multiple vaccines in clinical trials. Among these vaccines, there are 3 main targets, and we're going to focus on those 3 main targets and the most effective vaccine for each of these targets. Our first target and area is the pre-erythrocytic stage, when the sporozoite is traveling through the blood to get to the liver and invade said liver cells. The invasion of the liver cell is prevented. And if it can't be prevented, the liver cells are marked, so cytotoxic T cells can destroy the infected cells. Our most successful vaccine that is charging and trying to go against this stage is the RTS subunit vaccine, and it is the overall best vaccine out of all these trials. Our second target is in the blood stage. It stops the invasion of blood cells by merocytes, and it is done by targeting the surface proteins. The merocyte surface proteins are targeted along with the apical membrane, antigen 1, and Rh proteins. The merocyte surface proteins is what I have drawn here. The most successful vaccine that targets this is the P27A vaccine. And then we have our third target, which targets specifically gametocytes, specifically the constant transmission between humans and mosquitoes. There are two types of these vaccines, and these vaccines are known as vaccines to interrupt malaria transmission, also known as VIMTs. Our first type is the SSM VIMT, which is the sexual sporadic mosquito stage. And we have our second, which is the PE, the pre-erythric. Those are the least successful vaccines so far. All of this research and developing a working vaccine is really important to be able to help those in need, especially the young children in sub-Saharan regions of Africa. But as important as it is to develop a working vaccine at this time, it is also incredibly important to make sure it is available to those who need it. Many people who are affected by malaria cannot afford a costly vaccine, so only a few people will be able to use it. But we'd have to make it a little bit cheaper so many more people could use it, the people who really need it. But to do this, we have to make it cheaper, which can, again, be very difficult in the world of medicine. Here are my sources. Thank you for watching it.